people come to us all the time and they feel stuck. They're like, I have these ruminating negative thoughts or anxiety that's just going over and over, or cravings for alcohol and just repeated drinking even though I don't want to, right? They're stuck over here. And then you give them, they go through a psilocybin session and it seems like they get over here, right? So you open up this window where the brain is now, puts out all these new branches. It's like a sponge.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I am talking with Dr. Keith Heinzerling. He's the director of the TRIP program. TRIP stands for Treatment and Research in Psychedelics. Thanks for joining us.
Thank you. Glad to be here.
We've spoken before.
Yes.
A few years ago. Tell us what's new and what you're working on.
Thank you. There's a lot new. We're working primarily on novel treatments for depression these days using psychedelics, and also continuing with a clinical treatment program doing what's called ketamine-assisted psychotherapy, also for depression primarily, but also some other mental health indications.
Well, how many studies have you done at TRIP now? I mean, roughly.
We have completed entirely 3 clinical trials. It's funny because it doesn't sound like that much, but each of them is is a big pile of work. Psychedelics remain illegal at the federal level in the United States and illegal in California. Some states like Oregon and now Colorado have begun to the voters in those states had approved initiatives that allowed the state to authorize programs where psychedelics could be accessed for treatment in Oregon, and then treatment and actually personal use apparently in Colorado. There are some places that have decriminalized psychedelics, which doesn't mean it's legal, just means that the authorities aren't going to focus on psychedelics. But California, it's still illegal. And as a result, all of these medicines are what we call Schedule I drugs, the highest level of precaution and regulation, the most dangerous narcotics. And so there's quite a bit of time and energy just going through all the approval processes before the trials. But in short, we did a clinical trial of psilocybin for alcohol use disorder. That was a unique trial that involved a nature film as part of the psilocybin session. And we were a site for a couple multi-site clinical trials. One was psilocybin for major depressive disorder, and another was LSD for generalized anxiety disorder. And we have several trials underway at the moment that are in process.
What have we learned?
Well, 2019 was when I moved from UCLA to Pacific Neuroscience Institute, when Dr. Kelly had the idea to start the TRIP Center. And I've learned so much personally since then and professionally. And I think we as a society and as a field, psychedelic medicine, have learned a lot. One of the biggest things that happened since 2019, which wasn't specific to the TRIP program, was that the first psychedelic treatment went all the way to final review with the FDA, the Food and Drug Administration, and it was MDMA-assisted therapy for PTSD, and unfortunately it was not approved. And that was a very big learning process, I think, for everyone. We could talk for an hour about it, but I think the main practical point that relates to this topic from that is that people disagreed about certain things, but I think it's fair to say that everyone agreed that what is one of the most important priorities for psychedelics in the United States is high quality, reliable, valid, objective research on the potential benefits versus the potential harms, whether that's for therapeutic applications or other applications of personal use. Data is very useful, and it's cumbersome. It's very cumbersome to do psychedelic clinical trials, not only because of the regulations and the paperwork, but also the model of treatment is pretty labor intensive. So
meaning you have to sit with somebody.
Yeah, the people come in and they take a psychedelic in the clinic, and they may, like LSD. We had people who had 12-hour psychedelic sessions with the therapists and the doctors. We loved it as clinicians. We were like, we would do this 24-hour, give us a longer one. I found the LSD study to be really rewarding. And from a clinical perspective, it was awesome. But it is a lot of work. So getting each of these done and getting it done properly, objectively, with quality assurance and the data being collected in a reliable and objective way is a huge amount of work, huge amount of expense. We're glad to do it. That is our reason for existing, basically. So we're happy to do it. But despite the fact that there's been quite a bit of research since, I guess maybe it's been about 10, maybe 12 years since this, people call it the psychedelic renaissance. I don't know if that's really the right term, but when largely in the United States at Johns Hopkins, when, modern current psychedelic clinical research began again after long hiatus due to the legal status, there've been a lot of studies done. It's been a huge amount of work. People have really put their heart and soul into it. But when you look at like oncology or cardiology or some of the other areas of clinical science, there are tens of thousands of studies at this point that the evidence base for a lot of those biomedical interventions is quite deep at this point. So we have to remind ourselves that there's been a lot of anecdotal experience with psychedelics, which actually can be very informative. There were some pretty good studies done in the 60s, and we can reference those, but there's still quite a bit of research that should still be done using up-to-date scientific methods, and that's our mission. So we're happy to help with that if we can.
Are the clinical trials bearing out the promise of the anecdotal examples of one or two journeys with psilocybin helping people stop drinking? That's one story I've heard. The anecdotal evidence is quite powerful.
Yeah,
for a one-time, two-time experience changing a behavior.
Yeah,
radically.
I'll answer your question, but I think the first thing we should acknowledge is that anything anecdotal, it's usually an outlier. Either it's really good or really bad, right? That's how it
became an anecdote.
Yeah, that's how anecdotes work, right?
Yeah.
So there are many stories about, outlier experiences, really good or really bad with psychedelics, as there are with almost anything, right? As more and more studies are being done, more and more patients are being treated, more and more patients are being treated in places like Oregon, outside of the standard clinical trial settings. As more and more people use psychedelics, which is a big thing, because what happens with attention is that people say, maybe I should try that, right? And I have mixed emotions about that. I certainly don't want to limit access to something that could be helpful for someone, and I'm not interested in, controlling anyone's or interfering in anyone's private life. And I also think that there are really, really incredibly important, honestly, maybe more important than the medical applications, personal and spiritual applications of psychedelics. But we could talk about that more. Those are not something you just do without preparation or intention. So, but the studies have been if you do something enough, you start to get to the average, and you start to really get at what really is there, which is that there's people above and below the mean. So I would say that for depression, generalized anxiety disorder, alcohol use disorder, it is true that there's a pretty durable response within the time period that the studies have observed, which is generally like 1 month, 3 months-ish. The studies are very labor intensive. So you design a study and you have to come up with an arbitrary amount of time. And it's often just based on limitations of resource and cost. So
sure.
This was a big thing that came up with MDMA assisted therapy too, right? We would like to know more than what happens in the first 3 to 6 months. How about we follow people for a couple of years? So that is happening. Those studies like that, long-term follow-up studies for each of these medicines, psilocybin, LSD, MDMA, they are currently underway, but it takes a while to do that. So we don't have those results yet. But a fair number of people get a durable response from one dose of psilocybin. Whether it's going to be the only dose in their life, I'm skeptical of that. And I will tell you, I'm probably somewhat biased by my experience treating patients with ketamine-assisted psychotherapy, because ketamine and the classic psychedelics like psilocybin and LSD, they have very important differences pharmacologically, experientially. One difference is the amount of time that the psychedelic experience lasts. And some people dispute whether ketamine should be referred to as a psychedelic, but or MDMA for that matter. And certainly they're not the type of psychedelic experiences that some people would colloquially think of, which is home of psilocybin and LSD. But they alter one's consciousness. You can alter a patient's consciousness with ketamine, MDMA, psilocybin, LSD, and use that experience therapeutically if you know how to do it, or the person can use it therapeutically with guidance and support. And that's my definition of psychedelic therapy at the moment. Perhaps it should be, maybe psychedelic isn't the right term, but with ketamine, people often who are successful will do a round of ketamine-assisted psychotherapy with a depressed patient. If they respond, i.e. if their depression symptoms are significantly less or even gone at the end of a round of treatment, we let them go back to their therapist and their doctor, and they have our phone number. And what you see happening is that people do quite well for a while. And then 3, 6, 9, 12 months out, they'll often call up and say, I'm still doing pretty well, but there's a bit of a dip in my mood, and maybe I feel like some of that stuff might be coming back a little bit. And we say, well, why don't you come in, barring there being any change that would affect the safety of it, and after conferring with their clinician, their primary clinicians, why don't you come in and we'll do a couple booster sessions and just give you a little boost. And I anticipate that's probably what's going to happen with psilocybin and the other psychedelics. And in fact, we currently are recruiting patients for a clinical trial, which is a phase 3 clinical trial of psilocybin in adults for major depressive disorder. And it's a follow-up study to the phase 2 clinical trial, which we were a site for as well. That was the depression psilocybin study we completed.
Describe the difference between phase 2 and phase 3 for people.
There's commonly four phases to the clinical trial process. Although most of the attention is on phase 1, 2, 3, because after phase 3, if you're, and by the way, this is most relevant for drug development, which is typically being carried out by pharmaceutical companies. So we did a study of psilocybin for alcohol use disorder, and it was what we call an investigator-initiated trial. It was a study that we did. I wrote it up, and we did it ourselves. We were supported by the support of donors to the hospital and to St. John's Foundation and P&I Foundation, and that made that study possible. But the other studies we're working, there's a sponsor, so-called. The pharmaceutical company has a medicine, and a pharmaceutical company doesn't have clinics, doctors, therapists, or patients. They're in some skyscraper somewhere. They're a business. So they have to contract with sites around the country who will recruit and enroll patients in the study, and then those sites have to be equipped to provide the treatment. This is the same for psychedelics, depression, cardiology, oncology. It's the same model. So the pharmaceutical company wants to give the FDA data that supports the safety and the effectiveness of their medicine for the indication, which is the disease. And the first thing you have to do is phase 1. If the drug has never been in humans, you need to, and actually there's quite a bit of testing that happens not in humans prior to phase 1, but once that's cleared, then if the drug's never been in humans, you need to do a phase 1 study, which is essentially taking some healthy human volunteers who volunteer to take the drug at a very low dose in a very controlled setting, and you get the heart monitors and blood tests, make sure that it's not dangerous.
It's not gonna,
something untoward might happen. And if the drug has been in humans like psilocybin, there still has to be some initial testing of that in healthy people to make sure that what you think you know from anecdotal uses is actually true scientifically, although it's a bit easier if for psilocybin. And then those studies are also really important to try to identify what dose of medicine should you give and what's the range of safe doses. So phase 1 is all about safety. And then phase 2 and phase 3 are moving, they still include safety, you're always monitoring safety, but they're moving more towards efficacy and effectiveness, which are two words that differ slightly, but essentially mean, does the drug do what it says it should do, right? Does it actually, so for depression, does it reduce depression symptoms? And compared to what? Compared to placebo or an active placebo or another drug or whatever. Those are all variables that you can do in the design. So the process is phase 1, is it safe? And then phase 2, is it safe? And does it seem like it might kind of work? And then phase 3, is it still safe? And really, does it work?
Yeah.
And if you get to phase 3 and the data still looks good, you can submit that to the FDA and ask for approval, at which point the FDA will evaluate it. And if they deem the evidence to be sufficient and supportive, then if they deem the evidence to be sufficient and supportive, then they will approve the drug, which means that it can then be distributed to doctors and patients, and doctors and patients can legally use it. Then phase 4 is just after approval monitoring. A lot of really important stuff can happen in phase 4. We don't often think about it as a phase anymore because the FDA part it's less focused on the FDA. But oftentimes once a drug is approved, it may not be clear exactly which patients it's best for or how to best use it in the real world. So phase 4 is more about real world implementation, optimization of the medicine to try to maximize the benefits for patients and the public.
So you're in phase 4 on...
We're in phase 3.
3.
Psychedelics, any psychedelic medicine, the furthest that they've gone yet is phase 3. The furthest along was MDMA.
Yeah.
Made it to phase 3 and then not at phase 4 because they said, they didn't say go back to the start. It wasn't anything like that. They essentially, what happened with MDMA was that they asked for more research. They said, we see the phase 3 studies that you've done and we have your results, and we have some questions and we would like you to do some further research, another phase 3 trial to clarify some of the findings and make sure that, with science, it's never sufficient to do something once. It has to be replicable. To replicate it. That's very important. This is just my personal feeling. It's not a professional, statement, and different people could feel differently. I personally, I feel like of course, I'm a person. We worked, we did not participate. We were not a site for any of the MDMA clinical trials, really just by chance. We just, there's a bunch of studies out there and we were starting our center. And so we ended up working with psilocybin, but I'm close friends and I have a lot of colleagues who worked on those studies, and I know them to be, really good scientists and very competent and ethical. So I was disappointed because I was excited by the prospect that we may be able to treat PTSD with MDMA, because once it was approved, we don't have to go through all the hoops of study. We could just treat patients. So I was disappointed that we didn't get that opportunity. I mean, there are people dying, committing suicide with PTSD, right? So that's a real thing. That's a concern. But at the same time, as a scientist, I understand it's a very difficult, right? Like for scientists, there's never enough evidence, right? We'll be like, do another study. Yeah. So you have to balance the need of the population to have access to a potentially, and this could have been a life-saving treatment for some people, right? Versus the possible risk to patients, or, is there concern that the approval might lead to more people using MDMA outside of the clinic? Yeah. Those are real concerns that we need to talk about, but it doesn't mean that it's not like it's all good or bad, right? Psychedelics aren't completely good, and they aren't completely bad, because there's really few things in life that are,
of course.
The truth is that it's a mix, and really where you're using all drugs, I started my career doing addiction medicine, working with in HIV prevention, working with people who were injecting heroin
Mm,
and doing harm reduction
mm.
work to try to prevent people from spreading or contracting HIV or hepatitis or overdosing on drugs. And there you really can see how, yeah, I mean, heroin is a dangerous drug. There's not really too much really good reason to use it.
But isn't heroin, the side note, isn't heroin, according to the classification of drugs, I mean, psilocybin is Schedule 1.
So is heroin.
Okay, heroin Schedule 1, but what is cocaine?
Fentanyl. Well, there are some drugs that are abused that are Scheduled 2, like
Because
fentanyl,
they
because
have,
fentanyl is, in the hospital,
yeah,
fentanyl is a very important
yeah,
medicine, right? It's used in the operating room by anesthesiologists who have years of training.
yes,
Your
yes,
breathing is being controlled by a doctor, right? So
yeah,
if you're putting fentanyl into someone, and you're on a respirator and there's a doctor
yeah.
who's like checking your oxygenation and it's gonna like turn the machine up so you breathe fine. Oh, that,
Then you're good.
yeah, it's good,
Yeah,
right? But taking fentanyl at home alone, it's no wonder people stop breathing and die. It's not really
yeah.
that surprising. But the point is, right, there's an example, right, where the drug is administered, why,
Mm,
by whom, the context in which a drug is used has a lot of influence on the potential for good or potential
yeah.
for bad, right? So there are people, and I will, again, this is just my personal assessment. This isn't a professional statement, but I think most people who are familiar with psychedelics would agree that there are adults who could self-administer psilocybin, for example, um, in a safe environment outside of a doctor's supervision.
Mm,
Without a doctor's supervision, they could educate themselves, have a safe set and setting, have support, take precautions, be smart and respectful. Honestly, like
yeah, yes.
the psilocybin is a compound that naturally occurs in certain
Mm,
fungi, mushrooms, fungus, and has been used by people for thousands of years. And when you look at the people who originally discovered that if you eat this mushroom, strange things happen, right? They built around it ceremony, ritual. They made them sacred, religious, right? And that's an acknowledgement of the power of these substances. In a way, I mean, those structures are very useful in order to help get the positive effects out of the experience in the medicine, but they're also safeguards. There's structures around the use. They say you only use this sacred plant medicine, as people will call it. You only use this sacred fungal or plant medicine in these circumstances. You don't do it on your own, right? You do it there's a medicine person or a leader
yeah,
or a shaman or whomever, right? And there's oftentimes there would be even weeks of preparation to purify your mind, your body, your spirit prior to the ingesting the drug. And then afterwards, there's a community of people to help you adjust and interpret and integrate, as they say,
yes.
the experience, right? That's what these wise people who many, many years ago came up with to try to ensure safe and effective spiritual and communal use of psychedelics. We should learn from that and look, right? And so it's possible for a modern version of that to replicate that outside of a doctor's office. Doctors don't have to be entirely in charge of this, but for medical applications, when you're taking someone who might be emotionally or psychologically or physically fragile, severe depression, treatment-resistant depression, history of suicidality or something, there, I think maybe, doing it in a doctor's office with a doctor and a therapist, because these experiences, psychedelics they're disruptive.
Mm,
They disrupt and deorganize, right? They deconstruct. That is, even in the brain, you see neuroimaging studies that one of the effects of potential effects that might even underlie some of the therapeutic effects after psychedelics is a change in what's called the functional connectivity patterns in the brain, which parts of the brain are connected, and the preferred repertoires of activation of different parts of the brain, or the like preferred lines of communication. So it gets, the ruts, exactly.
Routes.
So,
depending.
well, you're in a rut with depression, and then it changes, right? So, that could be good, but it could also, there's a period of time in transition where things could go either way. Then on the other, so I don't know that someone like that may not be well served. It might not be safe for them to do something on their own. Someone who's got no psychological or emotional concerns, particularly people who are in touch with themselves spiritually or emotionally, people who meditate or have, right? Like psychedelics alter your consciousness. It's not the only way to alter your consciousness.
No.
There are other people who have experience with altered states through meditation or religious or spiritual practices. They probably have a pretty good foundation. They might be better equipped to experience psychedelics outside of a medically supervised setting. It's illegal. In California, that's illegal. I can't endorse that. It's illegal. I advise people against it. But I think we're seeing in Colorado that the law is changing, and I think that the law will evolve over time in the United States and the world in general to allow more opportunities for people to use psychedelics outside of a clinic. But for, ideally there'd be some way that people could get assessed or assess themselves and try to get into the right lane. People with medical and psychological problems, there should be a lot of oversight, really like professional, and people without, perhaps they're okay to go on their own.
Well, that's I'm from Oregon, and that's the case there has been that I'd call it the regulated,
yes.
We're trying to regulate the use of psilocybin. So you're only supposed to take it with a facilitator who's been trained in a service center that's been, approved by the state.
Yes.
Unfortunately, in Oregon, a lot of that is the service centers especially are very expensive because of the regulation.
Yeah.
Right? You have to have cameras, you have to have a safe, you have to all these things.
Yeah.
So what has happened is people will become trained as a facilitator, but they won't go to a service center. They'll do it, at an Airbnb with somebody, and it's like, it's going to take a while to get it right.
I agree. I agree. So hopefully there will be enough. And by the way, while we're getting it right, I really hope no one is harmed. That's always a concern, right? But it will take a while to get it right. And I think that it's good that there's a lot of these things are prompting a dialogue in society about psychedelics. And, it's something I think about in my colleagues, those of us that are clinicians and scientists working in psychedelics. I think that there's a sweet spot, perhaps. We started out very cautious. I think at least us at Pacific Neuroscience Institute, I'm happy to do this podcast. I know this podcast to be a source of reliable information. But I haven't gone out seeking a bunch of podcasts, I think some people, and even they may even be well-intentioned, but it can start to become more of a there's always hype about things, but we have to be careful and try to really present level-headed information about the pros and cons and not miss the potential, but also not shy away from the possibility that things could be difficult, and be patient and try to go slow. And, even though it was disappointing, and I think in the MDMA assisted therapy FDA review process, there were a lot of things that came into it's the first time, right?
Yeah.
So part of it was that it was like the structure to evaluate it was struggling with how to evaluate this new treatment. And then emotions came into it too. A lot of people were emotional on both sides. And I think that's only because people care a lot and on both sides, and, about safety and also about helping. And then it's just, psychedelics are intense. They're going to generate strong feelings in people sometimes, right? So you need to take a deep breath and try to stay with calm recourse and try to hear all the sides and not discount any one side. But the result, the rejection, so to speak, the failure of the FDA to approve the application so that MDMA could be used clinically, it wasn't a final rejection. It wasn't
Okay.
termination
Yeah,
of,
with prejudice.
yeah,
sort of.
right. Exactly. It wasn't, it was at the moment, your application is not, we can't put your application forward. You can go back and do more work, right? And so one thing that I think about from that is, you know, again, there are people who need help. There are people who don't respond to existing treatments. We need to keep that in the forefront of our mind, but also take a deep breath. Science, there's a process. Science is important. You know, be patient. If you're really dedicated, we just keep sticking to the
Yeah.
process, and there's setbacks and you just regroup and learn from that, right? Learn as much as possible from the experience and then get back on track and keep doing the work every day. So, you know, we don't need to be on a podcast to do it. It's the most important thing would be if we contribute some data to
Yes.
one of these medicines being approved for treatment in the United States, and then patients and doctors anywhere could access it safely. That would be the thing we would be most proud of.
Yeah. Well, legislators in Oregon have pushed to gather more data about people's experiences in service centers in the regulated settings.
Yep.
And, that again, because it's a drug that is still illegal under federal statute, that's led to privacy concerns.
Yeah.
And, but these are things we're going to work out.
Exactly.
Right. And I'm here to tell you that, we legalized psilocybin in 2020 and there are high profile stories about people having difficulties with it. Right. I mean, and then they make news.
Yep.
Right. They make big news, but there are not a bunch of people on the streets of Portland, Oregon on psilocybin.
Yes.
And there are a lot of people on the streets of Portland, Oregon on fentanyl.
Yeah. And there is, I hear you. And like I said, my first experiences in medicine were with opioid addiction.
Yeah.
And, for those people that don't know, fentanyl is a synthetic opioid that's highly potent. It's incredibly useful pain medicine in hospitals, but it's essentially replaced heroin.
Yeah,
for a while now, everyone just says fentanyl, but for a while, patients would come to us and say, "I'm doing heroin and I'm smoking it or snorting it or injecting it," and then you take their urine and send it to the lab, and they're like, "There's no heroin in there; it's fentanyl," and you have to tell them, or it's both; it's a mixture.
Yeah.
It's it's near and dear to my heart. There is some work underway, and at University of Wisconsin, some colleagues of ours are contributing to this to do some safety analyses to determine whether we could do clinical trials of psilocybin-assisted therapy for opioid use disorder. So it may actually be able to get people off fentanyl with psilocybin one day.
Yeah. Do we know why psychedelics work in this 1 or 2 dose way often for substance abuse, depression, unlike medications you have to take, say, every day?
Yeah. Well, why they work in general and then why they would have a sustained effect are related. Although the main thing that you have to do to answer that question is try to decide for yourself, at what level do you want to talk? And I'm agnostic about this. I'm open to all levels. And my guess might be that the secret to why these may work better than some other treatments is that they're working simultaneously on these different levels. But I always say to patients, whether it's ketamine or psilocybin or whatever, it can work on the body, the brain, the mind, and then what's beyond the mind, the psyche, the soul, the collective. I mean, I don't know, that's beyond my pay grade, right? But certainly the brain and the mind are related, we think, but how are they? And
how would you define the mind? What are you distinguishing there between brain and mind? Like the anatomical,
yes.
So the physical thing,
exactly.
Versus
there, I can tell you about studies about the physical effects of psychedelics on brain functioning, right? But consciousness, I mean, how do you define consciousness? What does consciousness come from? Does it come from the brain? There are very, very smart people sitting in rooms somewhere debating that right now, and I'm not equipped to answer those questions. But clearly, I think most people would say, right, there's something to being alive. It's not just for humans, but there's something to being alive that seems beyond just the physical, right? And what leaves when a human body dies? Something, I don't know. What is it?
Yeah.
Again, we don't know.
Start talking about conservation of energy and
Yes, exactly. And energy is, in the psychedelic space, people talk about energy all the time, and we don't talk about it clinically, but we probably have different terms for the same thing, to be honest, which is often the case.
certainly, yeah.
But for psychedelics, uh, on the brain level, you may get, like, let's take depression, for example, or alcohol use disorder, right? There are certain things about the brain in those conditions that may be not normal, quote unquote, or not the optimal arrangement of how the brain is functioning, either the connections or the patterns of connections. And when you take a psychedelic like psilocybin, there's a massive burst of activity all over in the brain. And some people have equated it to kind of like a reset,
Yeah.
whether it's there's something that was there was a lot of interest in the default mode network, which is the
Yes.
resting, what happens when the brain is at rest. And then, like I was saying earlier, patterns of functional connectivity. Those are at a level of, you know, the pathways in the brain and the connections between the different parts of the brain. Um, but obviously you can go all the way down to the molecular level in any tissue in the body. And one of the biggest things that is a buzzword at the moment, but I think really has a lot of potential, and there is increasing scientific evidence about, is that psychedelics as a class of medicine seem to trigger what's called a window of neuroplasticity.
Oh, yeah.
So there are experiments where they take a nerve cell, and it's in it growing in a petri dish. That's not exactly how it works, but for an analogy, it's in a petri dish in a lab. You've got a cell. A nerve cell connects to another nerve cell through the branches, right? That's how the signals propagate. And if you could treat that nerve cell with saline control, just like a control not supposed to do anything, and nothing happens. You could treat it with psilocybin, and it doesn't grow new nerve cells. That's neurogenesis. But what does happen is the nerve cells that are there put out new branches, making new connections. And it's very hard to prove that that's happening in a living human brain.
Mhm.
There's indirect measures of that, but I don't know that with the current technology we'll ever be able to prove definitively that that's what's happening. But when you start to put it together, right? Like, people come to us all the time and they feel stuck. They're like, I have these ruminating negative thoughts, or anxiety that's just going over and over, or cravings for alcohol and just repeated drinking even though I don't want to, right? They're stuck over here. And then they go through a psilocybin session, and it seems like they get over here, right? So maybe their patterns, and the adult brain doesn't really want to learn new things after a while, right? So you open up this window where the brain is now puts out all these new branches. It's like a sponge. And then that's where I think combining psychedelics with something, psychotherapy or behavioral therapy or something, makes a lot of sense. Because if you open this window of neuroplasticity, which is essentially like the cellular aspect of being able to learn new things, then why not teach someone something or give them something to work on, right? That could be healthy. So once the brain wakes up again, it might be ready to learn. And there are compounds called neurotropic factors, of which brain-derived neurotrophic factor BDNF is one of the most commonly known. And psilocybin, in certain lab experiments, seems to and all the psychedelics seem to cause the neurons to make those factors. That may be how it works. Turns out that antidepressants seem to do that as well, but very weakly.
Very weakly compared with,
which is why you probably have to take it every day for 6 to 8 weeks before it kicks in, right? Psychedelics do that potently. One dose, boom, right? And then you set off. First of all, there may be a structural change in the brain that persists. So you give one dose, you get a structural change in the brain. That's there.
Yeah.
You keep using it, it'll be reinforced. Then you don't have to take it again, right? But if you're making that change a little bit every day, taking antidepressant, it may take months and months to get there. We don't know for sure, but that could be it.
What about, does that raise the question about microdosing?
I'm glad you brought that up. Microdosing, it's fascinating to me, and I really want to see some research, but it actually almost should be dealt with as a separate topic from all the research that's been done, because the overwhelming majority of research, when people are talking about, oh yeah, there's all this promise of psychedelics and there's all this research going on, it's almost exclusively with what we would call a psychedelic or a heroic or a shamanic or a full dose of psychedelics, which for, don't do this at home, please, but just for scientific purposes, in the clinical trials for depression, by the way, we're using pure synthetic psilocybin in a capsule. 25 milligrams is the dose that people have settled on.
25 milligrams.
25 milligrams of pure synthetic psilocybin, which is the amount of that's the amount of psilocybin approximately in 4 grams of psilocybin mushrooms.
Okay. So that's
you eat 4 grams of mushrooms, only a little bit is the psilocybin. You're eating a bunch of other stuff. Now, what if all that other stuff in the mushroom is important and helpful? That actually could be, right? I mean, look at cannabis, whether it was God or nature or evolution or Mother Nature, somebody put together THC with CBD and all those other compounds in a cannabis plant. And it turns out CBD counteracts some of the bad effects of THC. Somebody wise put those together. Right? And then what do? We go, here's a pure THC capsule. And then you wonder why people are having panic attacks and withdrawal, right? So perhaps the mushroom is important, but just FYI, to date, there's not much scientific evidence to prove that. And, I mean,
they haven't done the, well, we didn't know about all these other compounds in cannabis, right? I feel like that came about in the last, 10, 20 years. Maybe other people did know about it.
Yeah,
but
it was known just like by the plant biologists, but no one thought about those clinically. I've witnessed people on 25 milligrams of synthetic psilocybin and pretty much looks like 4 grams of mushrooms to me. So, no, just anecdotally and just qualitatively, no major differences. And then, there's all kinds of strains now that are coming up, just like with cannabis. And I just want to say, with due respect to folks who have tried to make a rational policy towards cannabis in the United States and in all the states, I really hope that psychedelics don't use the same path to legalization as cannabis.
Why do you say that? Because say more about that.
So I think the way to think about harm from psychedelics is that the frequency of significant harm occurring is relatively low. Quite low, it seems, actually. Many people may take a psychedelic and only a few have something happen. But when something bad happens, it can be very serious. Physical injury from someone falling off of something, it can be serious. So, and although cannabis, I mean, honestly, if you look back, I'm not an anthropologist or a sociologist, but if you look back, it's hard to find. I mean, most indigenous societies and cultures, as I understand it, generally had a very inherent respect for nature.
Again.
Right? So cannabis is actually used ceremonially many times, and tobacco for that point, right? So we could say the same thing about nicotine, right? I would not want cannabis to follow in the footsteps of cigarettes, and I don't want, right? Like we need to treat these compounds with respect. And oftentimes I'll end up saying to patients that, in other cultures or past communities, they had sacred. We are in a modern secular society. We don't talk about sacred as much. So our prohibition is illegal, which is a shame because illegal probably isn't really the best way to apply it. But that doesn't mean that it should just be free form, go for it.
No.
Right?
One's kind of an affirmation with, like you say, guardrails or respect. And the other is a prohibition with.
Yeah. And I guess I'm not a professional in terms of evaluating the cannabis regulations, but it seems like there's been a lot of, commercial influences, and there's still quite a bit of non-regulated, right, illegally grown, cultivated cannabis is still out there. And so I don't know what the lessons learned would be for psychedelics, but looking at what happened with, what the outcomes of cannabis regulations are and trying to learn from that and inform what to do with psychedelics. But I do think that, with all due respect to cultures that use tobacco and cannabis spiritually and ceremonially, and they can be very powerful. I think it is fair to say that psilocybin, or not to mention DMT or ayahuasca, was very powerful medicines, spiritually, psychologically, mentally. To answer the question about microdosing, there's much less research with microdosing. To be honest, the few really well-controlled studies in lab settings, human lab settings with microdoses like of LSD mostly, have shown that it's basically not distinguishable from placebo. Now,
I've seen
these are studies where you take healthy people and then you go through a bunch of tests like math tests and thinking tests and attention tests, and they do fine because they're quote unquote healthy or normal, right? And then you give them a little bit of LSD to see if it improves it. You don't see a big change, but admittedly, I mean, maybe they just already are doing fine and they don't need to microdose, and they're not going to see a big change because they're already fine. The other possibility is, I mean, the two things when I think about microdosing, which aren't necessarily fully bad as long as people understand what they're doing, is maybe, you feel a little smarter and a little more alert, but it may be not something that comes out on a scientific test, but maybe you do feel a little better. The other thing that happens outside of studies when people begin microdosing is, I mean, there are so many things that happen in someone's life, their lifestyle, their social connections, their mindset, that gets them to the place where they would go and get microdoses of LSD. Like, that's a pretty big thing for the average person probably, right? Maybe it's all of that. Maybe just the intention of being more mindful about yourself is what does it, right? And they could be getting microdosing a placebo for all I know, but I would like to see research. I definitely don't want scientists to be, messaging me, there's no negative proof saying that microdosing wouldn't work for depression. There's a lot of hypotheses based on, what we know about psychedelics to suggest that small doses of a psychedelic 2 or 3 times a week could be an effective treatment for depression, anxiety. The only thing I say about that is that that's taking classic psychedelics work on the serotonin system at the start.
Yeah.
They're serotonergic drugs, right?
So when you say serotonergic, it is...
Psilocybin and LSD are what's called agonists, agonist. They bind to a receptor and trigger the response. That's when an antagonist binds to a receptor and doesn't do anything and then blocks other things. So it's a negative effect. And then there's partial agonists, inverse agonist. It's really fascinating, but mostly it's the gas pedal or neutral, or the brake. And
this is the gas pedal for
5-HT2A, the 2A serotonin receptor. Is the one that psilocybin and LSD have the highest affinity for. LSD binds a little bit more to some other stuff, including dopamine. And there may be some other off-target, as they're called, effects of the psychedelics that are important. I'm not discounting that, but for me, there's a lot of ways that psychedelics could be useful, but what got me interested in it was the psychedelic experience, the idea that altering one's consciousness could be something that was meaningful and beneficial and therapeutic to humans. And expanding, I would add, over the course of these years, I would add some nuance to the altering, and I would say, expanding your consciousness, because, sometimes there are people who have and microdoses don't do that. They don't, by definition, it's a small dose and won't create a psychedelic experience.
Just a side note there, is there any evidence that, I guess we don't know this, that microdosing would have that same effect on dendritic?
Oh, it could. Yeah, I think it could. But you'd have to it would be like with SSRIs. Yeah. So you'd take a small dose of LSD over 3 or 4 weeks and you might get the blossoming.
Yeah.
I suspect that is true.
Okay.
But it would be proportional to the dose, right? So, but that's not proven, but I'll bet you that'll be true. I'll just say one thing as an aside. The pharmaceutical companies, they don't want psychedelic experiences. They're not against psychedelic experiences, but for them, it's a nuisance. Yes. It would be easier if people just could answer emails while their brain is being tweaked or whatever, right? Just so having to have therapists and doctors there to support people during this very intense emotional mental experience is labor intensive and costly, and they want it to be, and there's a lot of arguing about this and people taking both sides. I do think it's important, even for people who feel that the psychedelic experience is very meaningful and important, to acknowledge that the cost effectiveness, the cost of these things, it's a very valid thing to talk about. And we need more like working together, all the sides, and collaborating and dialoguing and having, people who have experience with psychedelics who are, indigenous cultures. And by the way, they should also be getting credit and probably like intellectual property rights or, reparation or some support or something, but that's a whole nother topic. But the psychedelic companies don't want to be psychedelic. They'd love if they could wash it out. And
they want to mail you pills in the mail.
Yeah. They
don't
want to have to do that
every day. Yeah.
And so there are some companies that have engineered compounds that are based on psilocybin or LSD or DMT, where they either don't have the effects at all, the psychedelic effects at all, or it's so mild that it, still gives the effects on the brain, but not the mind. Right. Perhaps those will be good. Maybe they'll, and like, if one person is a good fit for like the spiritual, mental aspect, and another person is a good fit for the strictly medical, biological, that's great. That'll be more options for people, right? But I think when there'll always be humans who will be curious about this, and I think it will always be meaningful. And it'll actually, we're going to see massive transformation of society in the next 25 years because artificial intelligence, really exciting biological work being translated finally. And ironically, artificial intelligence being used to analyze huge amounts of data is actually like one of the things that's making all of this hardcore basic biology science become potentially applicable. So we're going to see huge transformations, and what it is to be human is going to be an even more important thing for us to be pondering and thinking about. And, there's a potential for psychedelic experiences, sometimes people have the experience and they come back, and I'm always like, it's like kind of like in the 10 Commandments, or like God gave like the 10 Commandments, or a voice came and was like, Anthony, right? Sometimes people come back and they're like, it's my job, I need to, right? They have these insights. Although honestly, we tell people, don't make any major changes right after a psychedelic session. That could be a good idea, or it may not. Like,
don't quit your job.
Give it a little space, right? And talk with the therapist. And if you need a different job, let's maybe like work towards a realistic way for you to get some training and make some changes. And don't be, don't go off recklessly, right? But sometimes people come back and they do have some insight or a message. I don't dispute that. But I think a lot of times what is powerful about the psychedelic experience is just seeing firsthand that there's this whole world out there of experience and data and knowledge and ways to like interact with the universe that are not through our physical senses. And just seeing it, and you can describe it to someone, but to be there and experience it firsthand is so just, it goes at the core of who we are and what our place is in the universe. And it's really can be really transformative, but you don't need to do that all the time.
No.
Like you go, people keep going back there, and I'm like, you got the message.
You got the message.
Were you listening? Like, that's it. The universe is massive. It's powerful. We're just little ants. And what are you going back for? Right. And it's like, I told you the first time, our brains are not equipped to process the level of information, the density of data that's in that realm.
No.
You just have to, tip your cap and nod and be like, wow. It's like, I don't know if you've ever, I don't know where it would be in Oregon. I can think of some in what, like Yosemite Falls. I always think of, you go to the top of Yosemite Falls. It's dangerous there. You could slip and get swept away, right? But you stand there when it's going and the water is, and it's just the awe of how incredibly beautiful, powerful, and dangerous maybe.
Yeah.
You feel a sense of like, where humans fit into the universe, and we're not the top dog all the time. And
Hmm.
that's very refreshing. And so sometimes the experience can be that, and it doesn't have to be like, oh, it's not necessarily in English even.
Yeah. Well, one thing that, when you describe the ceremonial,
Hmm.
the way it was done in the
Yeah.
past with cultures that had respect.
Yeah.
I mean, I think the idea behind Oregon's system was to look something like that,
Hmm.
right? I mean, before this Renaissance, it was like, you take mushrooms and go to a concert, or
Yeah.
that was not. I mean, if that was happening, it wasn't,
Yeah.
as popular as in the zeitgeist as it is now.
Hmm.
And the idea is, let's do this in a place with a person, a facilitator instead of a shaman, a
Yeah.
service center instead of
Yeah.
and so I think that's progress,
Yeah.
right? I mean,
There are people who have been working very hard in places like Oregon and Colorado, developing the programs, who have paid a lot of attention to this. I know, but still, it's always something to think about, and it's tricky. It's a difficult one. We don't want to appropriate. And an appropriation is a term. It's got a lot. It's emotionally charged, so we have to be careful with it. But um, a therapist or a medical doctor, we have a certain amount of training and credentials and experience, and we're coming culturally from a certain place. And indigenous healing practices come from a different place with a different set of credentials and training and cultural foundation. And so we, if we're trying to develop a modern, whether it's a therapeutic application of psychedelics or a spiritual application, it can be ceremonial. It could be ritualistic. Going to a doctor, there's a lot of ceremony and ritual that happens in surgery, i.e., checking the vital signs and setting up everything. There's a reason that we call them procedures, but other people might call them ritual, right? We can learn from that and do it. And we can even be inspired the way all creators, right? In anywhere in art, nothing is entirely original. So we could be inspired by some of the earlier practices, but we shouldn't attempt to take them and do them. There are people who are trained to do that. I would not, just like I'm a doctor, I'm not going to try to be a therapist. I'm not going to try to be another profession, right? That's not my job, right? So we have to be careful about that. But I do think that there's a lot to learn about how to do things well by looking to others and the past, and that there can be modern ceremonial use of psychedelics that is adapted to fit the needs, the culture, the consciousness, honestly, right? Our minds, our brains are pretty similar, but our minds have evolved a lot, I would say. So we need ceremonial processes that fit modern people. And a subset of that would be the ceremony that is the treatment process in a medical setting. I think no one would call it a ceremony as the first name, but there are ritual or ceremonial aspects inherent in even just your annual physical is a ritual.
Yeah, certainly. Yeah.
The doctor does certain things, listens to your heart, we check.
Yeah, that's a really interesting way to think about it.
You walk in and you go, "How you doing?" Right? It's all.
I would say in Oregon, it's ceremony informed.
Yeah. Yeah, exactly.
Yeah.
And doctors and therapists leverage these procedures, rituals, techniques, hopefully to benefit, right? To help people change for the better. They're very powerful. So we should also look and learn from how, ceremonial and ritual indigenous people understood how to best utilize and leverage the power of psychedelics for good. We can learn from that and try to use the structure. A lot of the clinical trials have something called they call it psychological support. People come in and they take a dose of the medicine, and we're never going to get to this, but we haven't even talked about placebo effect and expectation. That's a huge thing, but they take the medicine and they're accompanied by a therapist, but the therapists in the clinical trials don't actually do anything. They're there to provide support, kind of like the lifeguard. If something's happening, we'll address it, but also just to be another human there to help them ground and remind them of the safety instructions and just be a human presence when needed, right? And the reason that that's done for a lot of these pharmaceutical trials actually does kind of make sense, that you're trying to isolate the drug effect. It's the model is the model that's used for an antibiotic or an antidepressant or a cancer drug, right? What is the specific effect of the drug as opposed to all the other things it could be? So you want everything else to be exactly the same. So they really need something standardized that's just like as vanilla as possible, because what you want in the end, you want to compare psilocybin 25 milligrams versus blank placebo. So the studies are models, they're experiments, right? What's good for an experiment may not be the model for how you later use it clinically in post-approval. So I don't think that, sometimes I think people get a little bit too caught up in that. We'll have to do additional research later to show which ways of adding therapy are good or if not, right? But I do think that, what's there in the psychological support compared to a ceremony is the bare basic structure and framework that's there for safety. But honestly, psychedelics might be more powerful than we see in clinical trials if they were used with some of the ceremonial, because the placebo effect, we're doing a study and you're trying to minimize the placebo effect, everything to keep it objective. Then you go and you treat a patient and you don't use the placebo effect, but if they, you try to generate, you don't want them to have unrealistic expectations, but you obviously try to grab a hold of any hope and inspiration and use that to help them to change. That's kind of what we do. So there you're almost like, oh, this is a tool. And over here, it's in the clinical studies, it's bad.
That's really, because the placebo effect is huge.
Yeah.
And
psilocybin may enhance that's a whole other topic, but if it makes people better, and it doesn't hurt them, and you're not lying, you should not deceive people. We should be honest about how it works eventually, but they get better, what's wrong with that?
Nothing. Dr. Heinzerling, this has been fascinating. I really appreciate your time on this.
My pleasure.